Hello there, I'm Scott Sattler,
I'm Josh Cooper.
and we're the two board certified plastic surgeons at Sound Plastic Surgery here in Seattle, Washington. And this is a podcast on breast augmentation.
Today we're going to answer questions that patients have asked us over the years, and we hope that these answers and questions will be useful to you as you think about the breast augmentation operation. One of the most common things that we like to discuss with patients is what breast size they're looking for and what sort of shape they're looking for, and we want to really address and really understand what each patient's goals are. So first we're going to discuss today what the typical breast augmentation consult covers.
Yeah, we meet with patients here in our Seattle clinic, get to know them as people and review their medical history and find out what their desires are for breast augmentation. I typically start out the consult by asking patients what they like and dislike about their breast currently, and then ask a few questions about what their cosmetic goals are for their result. It's helpful to us to have patients bring in photos because we can look at the photos and discuss them with patients, and it really helps us assess if the patient's cosmetic goals are realistic and if we can achieve them technically given the patient's anatomy and the implants that are available to us.
When we speak with each patient, it's important as far as goal setting is concerned to find out if patients are looking for an augmented look or kind of a more fake look, or whether they want to have a more natural look. That'll help us decide what size implant to use and also what type of implant to use as well.
Yeah, there are a variety of implants available now in the U.S., even more than were available just 5 years ago. We discuss those implant types with patients and make some general recommendations on what implant type we think patients should make. Just to review this, there's smooth round silicone implants which have been available in the U.S. since 2006, and that's what we have the most experience with just because they've been available to us our entire careers. About a year and a half ago, the FDA approved a textured form-stable gummy bear implant, which is a silicone implant that has a very highly cohesive gel fill, which is an excellent implant for a particular patient subtype. And then lastly, there's saline implants, which have been around for many, many years, have an excellent safety record. But we're using them less frequently now that people recognize the advantages of silicone implants.
Yeah, absolutely. During your breast augmentation consult, after we understand what your goals are and we take a good medical history, make sure that you're healthy, we then want to kind of clue in on your exact breast shape. So we'll do a thorough breast examination with either our nurse or medical assistant in the room with us, and then we'll take some measurements with regard to your nipple, your inframammary fold crease, and of course we'll do a breast examination. This also includes looking at your breast width and looking at the relationship between your nipple and your inframammary fold, which is that crease underneath your breast. After that, we'll go ahead and actually take a look at some silicone breast sizers, and actually Scott and I step out of the room at that time and let you go over that sizing with Julie, who is our nurse here at Sound Plastic Surgery. She's amazing. She's helped sized hundreds of women for breast augmentation, so she's very experienced. And with her help in sizing, your goals, our recommendations on what size range is best for you, you will help us determine exactly which size implant to have on the day of your operation.
Yeah, it's important for us to actually have a definitive implant choice on the day of your surgery. So we're spending the allotted operative time performing a safe breast augmentation and not switching back and forth between several implants. We really want to know the implant that we're going to use on the day of surgery. That's extremely important. Just mirroring some of Josh's comments, if you want that augmented look, there's a way to create that using some sizing techniques and matching the diameter or the base width of the implant to the width of your breast. That'll give the breast a rounder and more augmented look. And if you want to look natural, then we typically recommend having the width of the implant a few centimeters narrower than the footprint of your breast, which typically makes the breast look more natural, less round. And that's kind of our general sizing philosophy. There's a few more nuances to it, but that's really.
It's important also to realize that during your breast augmentation consult, there's plenty of time for you to ask any question that you have of Scott or myself. And after you leave the office, you can always give us a call. We're happy to talk to you personally on the phone and answer any further questions that might come up after the consult is over.
Yeah, when we finish the consult, we generally, as Josh stated, patients do some sizing with our staff, Julie Parmer, or our medical assistant, Lindsay. But at the very end of the consult, Julie Parmer will discuss a full fee quote for you, which includes the surgeon's fee, facility fee, anesthesia, implant fee, garment fee, and then all the aftercare that you'll need really for the rest of your life or the rest of our careers. And that's all included, so there's no real hidden costs. You know exactly what the costs are when you walk out of the door. And that's the way we work it.
Yep, pretty straightforward. One thing we should also mention is sometimes patients come in desiring breast augmentation, but they also actually need a lift.
Mm-hmm.
I think we should discuss that a little bit.
Yeah.
Sometimes if a patient also needs a lift, doing simply a breast augmentation and not doing the lift procedure will really produce results that look less than ideal.
Yeah, I think that's a good point. Women experience some deflation of their breast tissues as they go on with life after they've completed breastfeeding or after pregnancy or after weight loss even. And that deflation phenomenon is typically characterized by a loss of upper pole breast volume, sagging of the skin envelope, and also some sagging of the nipple position. And so when you meet with either Josh or myself for an augmentation consult, we'll comment on the other features of your breast besides just the volume issues. So a few words about how we actually do breast augmentation surgery in the operating room. The procedure takes about an hour to do. We typically do it under a general anesthetic, but sometimes under a deep IV sedation. In both cases, the anesthesia is monitored and provided by board-certified anesthesia providers at the two surgery centers that we use. After the patient wakes up from the surgery, they're placed in a compressive garment, and aftercare instructions are reviewed with their caregiver, who always accompanies the patient to and from the surgery center. And then the patient goes home the same day. We typically call our patients in the evening just to check up on them, and we always give our surgical patients our cell phone number, so they're in direct communication with us whenever they need us. And we typically see our breast augmentation patients a few days after surgery just to check on how things are going, make sure pain control is adequate. Yeah. Anything you want to add?
Before the operation, on the day of your operation, Scott or I will mark you with a marking pen just before you go back to the operating room. So we'll see you before you go to sleep. And yeah, just as Scott said, the post-op recovery is pretty straightforward. Some patients will take 3 or 4 days off of work. Some patients will take an entire week off of work. For most patients, the operation is not usually as painful as they think it's going to be. We prescribe narcotic medication that most patients take for 2 days, 3, 4 days. Mm-hmm. And then patients usually switch over to Advil or ibuprofen and Tylenol, and that usually controls the pain just fine. Mm-hmm. We don't have our patients engage in any real strenuous activity for the first month, and by real strenuous, we mean no real heavy lifting, and basically.
A couple things I'd add. We found using a long-acting local anesthetic called Exparel, which is a form of bupivacaine, which is a local anesthetic that lasts quite a long time, has been really, really helpful for postoperative pain control. The bupivacaine is the Exparel medication is placed in the patient's tissues during the operation, and then kind of elutes or lets go of the bupivacaine slowly over the course of about 72 hours. And that really diminishes our patients' need for narcotic pain medications, which always have some substantial side effects. So Exparel has been a really important adjunct to our postoperative regimen. Josh, what do you tell your patients in terms of activity and exercise restrictions post-op?
Just after the operation, I like patients to take it easy. Doesn't mean that they have to stay at home and lay in bed. Being up and walking around is great, but I do tell my patients not to do any heavy lifting, meaning no lifting really over 20 pounds or so for the first few weeks. Exercising's fine as far as walking and eventually a little bit of light jogging, but I do like to wait on jogging and things of that nature until I see patients back about a week later.
Yeah, some of our patients are quite athletic and work out in gyms, do CrossFit or weightlifting, etc. And we typically tell patients the first few days after your surgery, we want you up and walking around. So things like stair climbing or elliptical machines or even walking is totally okay. But really want you to hold off on weightlifting exercises, especially exercises that activate the pectoral muscles, for about 4 weeks. Really just to help the implants settle in place and kind of stay where we want them.
Scott, what are your thoughts about placing the implant above the muscle or below the muscle?
Yeah, that's a really common question. The thinking about this has evolved over the past couple of decades, and I think now the most modern decision-making about this is that implants behind the muscle have a substantial advantage to implants that are above the muscle for a couple of reasons. One, an implant that's covered by a pectoral muscle, which is a large flat muscle, covers the chest, starts at the humerus here at this bone in the arm and then inserts down into the sternum, actually provides quite a bit of soft tissue coverage for the implant. So it makes the implant look less like an implant and more like a breast. Additionally, the presence of that implant behind the muscle, or the fact that the implant is behind the muscle, protects the implant a little bit more. So if you were to, receive some trauma to the chest for whatever reason, that implant would not be as exposed to that frontal impact as it would be if it was sitting on top of the muscle. And then lastly, I think it's pretty clear, at least in the recent literature, that the rate of capsular contracture or scarring around the implant is diminished in patients that have the implant when it's behind the muscle. And the reasons for that are somewhat technical and probably not completely understood, but I think that's a pretty well understood clinical fact. Josh, how do you go about actually placing a breast implant in the operating room?
So during the procedure, once our patients are asleep or have deep IV sedation, we go ahead and make an incision through the skin, which is usually, in most cases, underneath the breast, in what's called the inframammary fold. And once that incision is made, we go down through the subcutaneous fat, and we find the edge of the pectoralis major muscle. Yeah. We then lift that muscle up and actually divide a portion of the muscle where it inserts onto the rib cage. Doesn't mean that you won't be able to use that pectoralis muscle later on, because we still leave the insertion of that muscle on the breastbone or the sternum. And once we lift that muscle up, we then create or dissect the breast pocket. And once that's done, once we're finished with that, we then go ahead and irrigate or bathe that breast pocket with triple antibiotic solution. We then grab the implant and also soak that in triple antibiotic solution, and then we place the implant into the breast pocket. So those are basically the technical details, and then of course everything's closed. Skin's closed, and then we go ahead and use local anesthetic and put a surgical bra on.
Yeah. Josh, do you use any drains when you do breast augmentation surgery?
I normally don't use drains. The only time that Scott and I usually would use a drain is if we're going to be placing one of the cohesive or highly cohesive gel implants that's shaped. And the thought there is that we really don't want any fluid whatsoever to gather around that implant, or else the implant theoretically would have a higher chance of rotating or turning. And if a shaped implant turns, then things are going to look odd, and that's going to require another operation.
Yeah, I agree.
One thing we should talk about today are some of the potential complications with the breast augmentation operation. There's both the acute potential risks that could happen at the time or just around the operation, and then there's some more long-term risks.
Yeah. I'll go over the acute ones first. The main issues, not in order of frequency, but just just to relate them, things like bleeding and infection. Those are complications that are inherent in any operation that we do, whether it's plastic surgery or cardiac surgery or even brain surgery. So bleeding and infection are really managed by just paying meticulous attention to bleeding, and also doing a couple of things intraoperatively which we think reduces implant infection, and that is to give the patient a dose of preoperative antibiotic prior to incision, actually during the induction of the anesthetic, and also using some antibiotics postoperatively. And then secondly, washing or bathing both the patient's breast pocket and the implant itself with a triple antibiotic solution. And that's been shown to diminish the low-level contamination around implants and maybe even reduce capsular contracture down the line, which Josh will discuss in a minute. And then I would say, another acute or short-term complication of the operation is just complications from the anesthetic. Younger women who tend to have breast augmentation are more prone to postoperative nausea and vomiting, especially when a general anesthetic is used. And so we always prescribe some medications like Zofran, which is also called Odancitron, or a scopolamine patch for patients to use perioperatively, and that really helps manage post-op nausea. Our anesthesiology providers or anesthesia providers are acutely aware of this problem amongst young women and do some things intraoperatively to also reduce the incidence of post-op nausea and vomiting. But Josh, what are more of the kind of mid-term and short-term and long-term complications?
So two of the main complications that we always discuss with our patients are breast implant leak or rupture, and also capsular contracture. So over the course of your lifetime, there's always a chance that that silicone implant could leak, and we usually quote that the chance of that's about 1% per year. And with the new models of silicone implants, there is less likelihood of leakage, I would say, than some of the older implants. The other big complication that is possible, although not that common, is a capsular contracture. And what that is, what that refers to is the capsule that forms around your breast implant. Whenever we place an implant in a patient's body, your body's natural response is to make scar tissue around that called the capsule. But sometimes that becomes abnormally thickened and hard, and then we term that a capsular contracture. Sometimes it can be so hard that it's painful, it can distort the shape of the breast. If that happens, we can go back through the same incision through which the implant was placed, and we can remove that scar tissue and replace the implant. We think there's probably a little less likelihood of capsular contractures with the newer implants, and also placing that implant underneath the muscle, which we do in most cases.
Yeah. Josh, is there a particular incision that you prefer for breast augmentation surgery?
Most of the breast augmentations I perform are below the, in the inframammary fold, which is basically underneath the breast. I find that with that incision, I get great visualization of the breast pocket. I can dissect out that pocket to match exactly the shape of the implant. I also find I can get amazing hemostasis, meaning that there's almost no blood loss during the operation, so that's my preferred method.
Yeah, mine as well. There's a couple of other options out there that we very rarely use. There's a periareolar incision, which is an incision between the darker areolar skin and the lighter breast skin. And that incision is useful for a couple of anatomic subtype patients, patients that have a tuberous breast deformity, some Asian patients that have extremely tight breast tissues. But frankly, that incision has a couple of problems. One, it's always going to be visible. The scar is going to be in plain view right at the junction between the darker areolar skin and the lighter breast skin. And secondly, the rate of capsular contracture using that incision is somewhat higher than the inframammary approach. And so for that reason, it's really unusual for us to use a periareolar incision, but we do have some patients coming in that request it. And then secondly, there's a transaxillary or through the armpit approach that can be used for either saline or silicone implants. Again, that scar, even though it's hidden on the armpit, will always be visible if you raised your hand. And it's very distracting to see a surgical scar across the armpit, even if it's hidden in a fold, simply because most people don't have scars there. So it's basically impossible to hide, and it's a permanent scar. Whereas the scar beneath the breast, we can hide it very well because there's a fold there to begin with, and it's virtually impossible to see the inframammary scar looking straight on a patient or even from the side. So it's like Josh, it's my preferred way to place an implant. And then thinking long term, it's also, the inframammary scar is also the ideal or the preferred scar for reoperative breast surgery. 20 years from now, if you ever wanted your implants out, or if you wanted a new implant or had to manage a capsular contracture or some other issue, that inframammary scar is the easiest to work through for reoperative breast surgery.